Hi, this is Marissa with Health HIV. Ken, did you just join the call? Kenneth, if you're logged in, this is Marissa Tonelli with Health HIV. I'm here with Dawn, and we granted you control. Oh, I see your phone showing up. I might do it. Ken, let me know if you can hear us. Great. Can you, would you try, I don't know if you have any audio. I tried to, I granted you presenter controls. Are you on mute?
Hello?
Oh, we hear you now. Great.
Okay. Cool beans.
Yeah, sorry, I had to get our Webinauto person in here. We have our operations manager, is the most savvy, and just showed me a little trick. For some reason, your mic was red. but I'm not quite sure why. So right now we're just waiting for Lena to log in, and then we'll get started from New York. Unfortunately, the Baltimore folks, oh, I see somebody's here, tried to make it, but they're not able to at this point because they're doing their APR. So busy. Great. Lena or the New York team, if you're able to utilize, great, you're on audio. Fabulous.
Great. Sorry about that. Sorry about being late.
No, that's okay. That is totally okay. It took us a second to get Kenneth up on audio. For some reason, he was automatically muted. So that's fine. We still have our representatives. Lena, are you there with anyone else, or is it just you from the New York side?
Ben isn't here right now, but we have hired a new program planner who will be working on 15-1509, and we'll be working with you all. Her name is Stephanie.
Hi, how are you?
Good, thank you. How are you?
Excited to have you on board. Good. Thank you. I'm glad to be here.
Awesome. So we are in our second meeting of this community of practice, which is a structural interventions work group. I've had the opportunity to speak with Lena a couple of times, but for the other two that are newer, I'm Health HIV Senior Capacity Building Manager, Marissa Tonelli, and I lead another cooperative agreement with CDC doing technical assistance, but am supporting the 1510 technical assistance and training team here and there, and particularly with the structural interventions work group. So I'll be the facilitator of this community of practice probably for the duration of its existence. And I'm here with Dawn Maker.
Hi guys, and just for Kenneth and Stephanie's awareness, I am the Education and Training Manager here at Health HIV and work a lot on 1510, but also work on some of our Hepatitis C initiative as well. So I know I've worked a little bit with New York already on 1509 and 1510 engagement, so I'm excited to continue that.
Great. So, and I know also our education director, Dana, is listening in, and she may or may not chime in, but she just wanted to be able to listen to the conversation and be a part of it that way. So if you hear another voice from our end, it might be Dana. So I just wanted to kind of, before we get started, review what we had proposed as the agenda, and we can move through the beginning pieces quickly so we can get into the discussion. And I just wanted to open it up. I don't know if, I think, Kenneth, I know you are in D.C. We heard Lena's voice and Stephanie's voice, but if you just want to introduce yourself quickly, that would be great to the rest of the group.
Sure. So hi, again, my name is Ken Pettigrew. I'm the program manager for this project. I'm new to Department of Health. I've been on board for about a month now, so still getting my feet wet on the project, but glad to be a part of it.
Great. Well, we're glad that you can join us. If you, I think, Ken, for you, if you were able to look at a couple of things that we sent out, we did send out the meeting minutes from last month, and we also sent out just some guiding principles for the community of practice that we had discussed during the initiation of the COP. If you would like to download them, if you don't have them, actually within Webinado, you can go on your screen to the bottom right-hand corner of the window. There's a little documents folder, and if you pop it up, you can see the minutes and from the last call for your reference, but we're not going to go through them in detail. But if you'd like to download them there, you can download them there as well, and same to Lena and Stephanie as well. So I know for the last call, there's a couple of kind of things that were discussed primarily with between New York and Baltimore, and I know the DC team wasn't able to be there, specifically around two implementation challenges that New York had identified that they were facing. And they opened it up to the group, to the Baltimore folks, to kind of respond to. And I know, Ken, you're new, so I'm not sure if these are anything you've been dealing with. But Lena, if you'd like, we can kind of pose those same topics before moving on to another topic if you're interested in kind of seeing how DC is dealing with their solicitation process and also some of the behavioral health services. Would that be of interest to you?
Sure. I mean, if there's time.
Yeah, no, I think it's just for your benefit, and since Ken wasn't on the last one, I think it's fine for us to hit on that. So you can, Lena, if I'm not describing it right, please chime in. But I know in New York, what we had identified the last time was for Ken, was that there was a procurement process that New York noted was hindering some of their ability to move the process forward with their collaborative partners. And what they had asked was if Baltimore had any of the same issues kind of implementing work within their collaborative partners, and if so, if it was something that they had best practice or any strategies for overcoming. So I don't know if you've had any of those kind of challenges in DC with your implementation, and if so, kind of how the health department is dealing with it.
So, haven't really had any challenges. Just to say where we are in the process, we have the collaboration has worked really well in identifying those services and things that we're intending to bring online relatively quickly. So we haven't really had any major issues other than I think the green light in terms of like spending. But other than that, we have not really run across any huge obstacles.
Okay, great. That's good to know. And then kind of the other, and so hopefully New York, you guys will be able to move forward and find a way to overcome that challenge as well. The other topic that had come up the last time was around integration of behavioral health interventions. And what we had posed to the group was kind of how you're implementing behavioral health interventions within this project and any successes and challenges you've had. So Ken, if you have any thoughts on that or anything that you guys have been doing in Washington, D.C. that you'd like to share, that would be great as well.
So what the coalition community partners came up with is there is a one behavioral health intervention, RISE, it's a homegrown evidence-based intervention that they have chosen to sort of integrate or implement across the region. That has not started, but that is the chosen one for us that we'll be using that as a first step in terms of behavioral health. That's behavioral health models that we'll be using. There are some other interventions that have been talked about, but that's the one that has been chosen for now. We're going to move forward with that one, getting some training done, initial training done like in the next 2 weeks on that intervention. We do have our behavioral health person from the government at the table now, and she's working with us in terms of some further integration, but right now we just have that one intervention that we're going to put out relatively quick.
Great.
Ken, hi, this is Dawn. Can you describe RISE a little bit more? I'm not familiar with that, and so I'd just like to a bit more about it.
I can tell you what it feels like. You're familiar with Many Men, Many Voices, 3MV?
Yes.
Okay, it is a deeper version of that. It really talks about the scripts that gay men of color may have experienced and the impact it has on how they show up today. So it's for lack of better words, it really takes something like 3MV to the next level, and understanding the scripts and how to undo those scripts that would, and it looks at all the aspects. It's a whole sort of the whole person. So it's not just sex. It's not just health. It's all of these things and the implication how they all merge together, but based on the scripts that most and the bad scripts that were played or are in people's minds. So it's 3MV probably on steroids is probably a good one. It's a rich, really rich. It's one that really does sort of take you back into why you do the things you do, and getting new scripts played.
Great. And is that something that you need? Oh, go ahead, Lita.
Yeah, just a quick question. So just to be clear, you're using a different funding mechanism, and clients from 1509 will be referred to this WISE intervention to receive all their behavioral health and social services or linkage to those services.
So yes, that's going to happen too. So yes, that's what we will have the linkage. And so we just hired, we just brought on our navigators. So the linkage to behavioral health across the region, we will have those linkage to other services as well too. But that intervention of itself will have some providers do that. But yes, we'll do both the intervention and the linkage to other behavioral health interventions and services.
Oh, so the intervention is your model for 09.
I'm sorry, I didn't hear that. Someone walked by.
The intervention is your model for 09, essentially.
For 09, I don't.
Sorry. For
yes.
Great. Okay. Thank you.
Great. And I had another follow-up question for you, Ken, related to that. How are you involving the behavioral health person, other behavioral health person within the health department? Are they sitting in on meetings? Like, what's the relationship there and their involvement in the project?
Was that to me? I'm sorry.
Oh, I'm sorry. Yeah, sorry, Ken, that was to you. You mentioned that you were involved in a behavioral health person, and I was just curious how that was, if they were staffed on the project, or how that worked, how the relationship worked for the 1509 project.
We just gotten support from our Department of Behavioral Health, and so that person is now on the part of the coalition, and will be giving guidance around appropriate services and things that will be needed. So we have that collaboration now, and she's very interested. She attended our collaboration meeting on Friday. She's very much interested and can make the connection on how the Department of Behavioral Health can work in providing services as it relates to the 1509.
That's great. Lena, just out of curiosity, do you guys have, I don't know if your health department is already integrated and they're part of the 1509 project, but is New York doing something similar with working with their behavioral health division or department?
Actually, Ben just joined. I think he'll take a stab at this.
So the health department, there's a health part, and then we have a separate part that we call it mental hygiene. I have no idea why it's called mental hygiene. We have not reached out to them specifically for this. I mean, it's something we can look into, although we are very siloed. Okay,
yeah. No, that's I know that's kind of the sense of most health departments, so that's interesting to me. And Ben, since you're here too, thanks for joining us. I don't know if you've interacted. We have Ken Pettigrew from DC on the line, Don and I here, and then Dana's listening in just for your information. And I just wanted to remind everybody too, that if you have any questions or comments, the nice thing about Webinato is that you can type them in, and you should all have the opportunity also to private message if you wanted to private message myself or another individual, you can do that as well. So yeah, and there's a resource, the little documents folder, if you wanted to upload something, we have that ability to do that too. So please utilize it to its full extent beyond the recording feature, which is really why we have it today. So I wanted to kind of, with that kind of tying up from last month, Ken, did you have anything else on those topics, or Lena, did you have any other questions that you wanted to ask before we kind of move on to another topic area that was identified?
No, nothing comes to mind.
No.
Great. So one of the other, so again, this community of practice was really developed to talk about some of the initial implementation, successes, challenges, opportunities for improvement, et cetera. And so one of the other pieces that came up when we were brainstorming topics was how to integrate or implement this workforce readiness piece of the program. And so I just wanted to open it up. Maybe we'll start with DC and then go to the New York folks. How you are integrating workforce readiness and workforce development into your 1509 project, and if you've had any initial successes, challenges, or any other kind of innovative strategies you've implemented that you want to share with the COP.
So for DC, what we've done is, what came out of the coalition is like peer navigators or peer educators. So we're actually starting that May 1st. So we'll begin a solicitation of peer navigators. What will happen is that they may be recommended from an organization, but then they'll go work at another organization to give them exposure to something other than what they may be used to. So we'll start off with 15 folks. They will have the professional development training from HOSTA or from us. We'll also do some HIV training, some holistic training. But the goal is really to find consumers within organizations and then have them go someplace else to learn about other and hopefully the organization that they get assigned to is very different in population and in work.
That's great, and I know this came up on the last topic on the last call too. And Baltimore mentioned peer navigation and as one of their kind of training or workforce development models as well. So that's great. New York, I don't know if you want to share what you guys have been doing and if you've had any successes and challenges. And again, I know this came up the last time, so it's good to kind of share with the DC folks.
I think in terms of this, we were just talking that there are different aspects. One is sort of public health or care provider workforce readiness, but I think the other thing that we also want to talk about is for 1509 was looking at sort of like employment as a social determinant that can impact the health of MSM. So those are different things that we're looking into and we're doing in terms of workforce readiness or sort of like provider, CBO and clinical provider readiness to provide PrEP and sort of like support for linkage. We have trainings that we are getting ready or have started to provide for sort of frontline, so different levels. So we have trainings for sort of manager, sort of like there's trainings for those who provide PrEP and PEP services versus those who do the referral for PEP and PrEP services. So we have counseling training for frontline staff to talk to clients about PEP and PrEP, and then which could also be useful for those who are in clinical facilities. But then specifically for clinical providers, we have PrEP implementation workshops to think about what are the logistics systems you need to set in place to do this. And this is separate than training physicians or clinical providers to do this. It's really more of clinic protocols, making sure that you have the process in place so that if someone comes in and they're not insured, you know how to refer them, what are the different resources for all those things. And then we also are just starting to implement, or will implement soon, navigation training for those who are negative and for those who are positive, negative to PEP and PrEP services and positive to care providers. So those are some of the things that we're doing. And then I think in terms of, which we'll sort of touch on in terms of the how to measure, not so much the welcoming, is also getting a sense of with some of our agencies that we're working with PEP and PrEP, we're kind of looking at what kind of data they're already currently collecting so we can get some baseline, and then from there we'll use that as a basis to figure out how we can collect and what kind of data we can collect on PEP and PrEP services moving forward. Separately then, we have had other conversations with others about employment as a social determinant that can impact the health of others. So, and that has been eye-opening in many ways, just because it's not a conversation that we usually have in public health. So that we found out that there are vocational rehabilitation services available from the Department of Education that we can have some access to. However, for those persons who to access those services, we found that they have to have some pre-existing condition to qualify. So it could be HIV, it could be substance abuse or substance use condition, it could be a physical or chronic disease or some other condition, but then also has to be some vocational need for them. And then if they do meet those criteria, then actually the resource available to them could be pretty vast, including they would even pay for school and if needed, sort of like orthodontics, if they, let's say their teeth are really bad so that it impacts their ability to interview. So it's pretty amazing what's available. And then we're also looking in terms of, for those who are not HIV positive, what are other sort of like workforce rating, sort of workforce trainings that we can refer people to. So we're actually planning on having a employment training for providers, meaning CBOs and clinical providers, sometime, I think, in August of this year.
That's great. And just, I had one other question about the relationship with the Department of Education. Have you seen kind of what the process is like for someone to go through it, somebody with HIV, or have you heard anything from other providers that have made referrals there in terms of, is it a very slow process? Is it, does it move fairly quickly? How does it work? I'm just curious how they provide that.
This funding is actually coming from the federal level. It's a federal mandate with funding for that. We have had conversations with them. They will actually be one of the presenters at our conference, and we have started initial discussions with them that they're actually planning on having a dedicated or a person at their central office who will take referrals from us initially to help facilitate the process, and then moving forward as our volume, as we hope or expect the volume to increase, then we'll move forward accordingly. So we have at least had a verbal commitment from them that they will help expedite the service for our project. Wow,
that's incredible. That's really a great resource. I'm curious then, I don't know, Ken, if there's anything similar in DC that you're aware of, or a partnership or working with the Department of Education is something your team has looked into in DC.
Well, we have invited Department of Employment Services to the table. we had a little trouble getting someone to come, but in that same vein around, they have programs, and particularly geared toward MSM and transgender persons, where they'll do the training and hopefully get them into a job with or career or something. And they have a lot of agencies and organizations that they're working with in terms of placement. So we just began that conversation that some of the we'll be able to refer and work with them to get more folks through the doors in terms of employment opportunities.
That's great. That's really interesting. And then another kind of, I don't know if, Ken, if you guys have looked into this, but I heard one thing that another piece that Ben mentioned was around kind of determining what PEP and PrEP data that's already being collected in the community or in provider settings. Is that something you in DC have thought of or have any kind of initial successes or strategies around?
I didn't. You broke off at the beginning of this. I didn't hear the beginning of the question. I'm sorry.
Sorry, that's my fault. No, I was just highlighting something that Ben had mentioned, that they're looking into what PEP or PrEP data is already being collected in the community and how that can be utilized for some of the work that they're doing. And I was just wondering if that was something that DC has started to look into, or if it was of interest to you, and if you've had any successes or challenges with doing the same kind of activity.
Well, what we have pulled together is everybody's doing some little piece of PrEP. There may be a community-based organization just doing education. What we're finding is there are a lot of providers touching PrEP in some way. So we're trying to bring them together and sort of get on the same page in terms of. So the goal is to collect some data. Our chief medical officer is coming up with a protocol and a survey to do the assessment with the folks who are doing it. We definitely want to use that data because we do know that even people who may not be funded by the health department are getting these small grants around PrEP education from places like Gilead and stuff. So we definitely want to use that data and bring together what the providers are getting from the folks who are coming to see them.
Great. That's really great. And Ken, did you have any questions or any thoughts on what the New York folks shared about kind of the workforce piece? I know Ben kind of jumped on to clarify the difference that they're seeing or that they're addressing between provider workforce readiness versus readiness or workforce training of MSM of color and individuals that you're working with. So I don't know if you had anything else you wanted to kind of add to the conversation, or we can kind of move on. We can move on to the next topic.
And just FYI to workforce development, workforce readiness is something we are building into the curriculum as well. So we recognize that that is an essential piece and are also going to be addressing it further too.
Great.
Yeah. I didn't have anything else, but yeah, definitely am interested in that, just as we move in terms of what the pieces to that workforce development and workforce job readiness.
Great. Well, we'll continue to kind of share best practices, and I think in New York, you guys are doing a lot of great work, and if you're open to it, and as you're developing strategies that we can share with the broader group, we might have the opportunity to write something up and as a case study or a model of sorts for the other 1509s to benefit from your experience and work that you're doing as well. So the other piece that we wanted to touch on, or we had proposed to touch on today, was another topic that came up last month, and I believe it was the folks from New York who were curious about how to do trainings on medical mistrust, and it was something that Baltimore said that they were implementing. and New York asked kind of, what does the training look like? What is the outcome? How do you navigate a conversation with an individual who mistrusts the medical system? And so it sounded like Baltimore was still trying to figure out how they were going to implement this particular training on medical mistrust. And so I just wanted to open it up possibly for you, Ken, since we're kind of new to this particular conversation, and also allow New York, if you've had any kind of other findings or movement on that topic over the last month, to just weigh in on trainings or any sort of program related to dealing with medical mistrust of this particular MSMC community.
I think I'm not sure if we put medical mistrust as much as maybe it was Baltimore, but we definitely, what we hear more of is sort of like a welcoming environment from consumers.
Yeah, that's great. So maybe that's another way to rephrase it is, how do you, I know you guys were interested in talking about, how to either do training or how to kind of implement this welcoming environment in the community. So I don't know, Ken, if you guys DC have been doing any work on this in their 1509 project, and again, what your successes or initial challenges have been.
So we were going at it along the same lines that was just mentioned. So we have one of our work groups is dealing with a cultural competency. So we've actually sort of reframed how we're looking at providers, because the larger group does believe there is the mistrust is there. We're going to create a tool that really, it's not really cultural competency. We call it cultural flexibility. So when someone comes, how great are you? Like, for example, there are domains to what we call cultural flexibility. One is when I first walk in the door. 2 is the treatment. 3 is the voice, and so it's almost like these are the markers of an experience. And one of the ones that we're weighing heavy on, how does a patient feel they were heard, or the client feel they were heard? So we are coming up with a tool that will assess that. What we're going to do is not necessarily ding or say that that's a bad place to go, but that's our place of capacity building. So we're looking at this as a way of, for those agencies who may not have as much cultural flexibility, is how do we increase that? So that is part of our next steps in terms of, and part of the peer educators that will be coming on will be turned into secret shoppers. So they're actually going to go in and sort of rate the places. So again, it'll be another way to assess the sort of cultural flexibility in the agencies.
That's great. I don't know if New York, if you guys, I'm interested in kind of the tool development to assess kind of cultural competency. Have you guys in New York done anything similar, or have developed an assessment of sorts to do that?
We haven't. No, we haven't.
I haven't heard of, and well, obviously, you do trainings and things like that, but I haven't heard of that with the 3 domains. That would be, Ken, if that's something that you're open to sharing once you guys are developed as kind of a model, it might be something that other folks in the 1509 jurisdictions would be interested in taking a look at.
Sure. Okay.
Hi, sorry.
Okay.
Can you please just repeat pretty briefly what the 3 domains of cultural flexibility are?
So if you give me 2 seconds, I can actually get because I had to go to someone else's desk. I can get it for you. Can I get hold on for 2 seconds and I can get it for you. Okay.
Sure. Thanks so much.
I like the idea of the secret shoppers. I used to do that for restaurant companies here in DC as kind of a thing. So it's an interesting.
Great idea.
Yeah, that's a good idea. That's great.
New York, is that something that you guys have looked at or thought about as trying to, I know you guys haven't developed the tool, but assessing, cultural flexibility or, even a welcoming environment, is that something you guys have looked at in terms of how you want to start addressing it?
We've had like one listening session with MSM so far. We're planning on having another one and think of having one for trans women. I think it's interesting that we just even very recently had some internal training at the health department looking at sort of awareness, competency with the trans community, and I think the intersection is not. I think it goes more than just cultural orientation. That is that when you have these intersections of different things, that for one person, it may be race may be more of an issue than they're being transgender, or for another person, it may be being transgender, and being sensitive enough to know that the person in front of you is unique. And I think part of this is not pigeonholing them and letting them kind of dictating where their needs are and how they want to be treated. Right. But I don't know, but that makes it challenging in terms of how do you assess that.
Mm-hmm.
Definitely.
So the 4 domains were engagement, point of care, appeal, and the voice. So engagement is like when you first walk in, and point of care is like how you're being treated. The appeal is like how aggressive the agency follows up with you, and then the voice is like does the person feel like they've been heard? Are there feedback mechanisms?
Okay.
This is a tool that you are having CBOs complete or providers in general complete?
We're gonna do both. So they'll again we're gonna use we're gonna frame this in a way that some of our secret shoppers will look at these. Of course, we'll have to fix it in a way that they're just sort of checking off things within that box. But it's something that we'll have people go in, and in some cases we may grab a client as they're walking out the door. So we've thought about a couple of different ways to make that assessment. We certainly don't think that. So if we ask a provider to check their own, it wouldn't be like we didn't think we get good information. So it'll be done by somebody else who's had the experience rather than the provider themselves.
Got it.
And is this something that was developed based on like a evidence-based model that you found, or is it something that's been implemented before in DC? I don't know I know you're relatively new. I'm not sure if you know that. I'm just curious about how the 4 domains were identified.
So it actually came out of the cultural competency Workgroup, just trying to figure out a way, because I think it's been said on this call, assessing that. What are you looking for? The whole notion of, I've been dealing with MSM for 20 years. Of course, I'm culturally competent. And so when we were trying to figure out what were the things you would be looking for, and it actually just was grown out of the work group.
That's great. That's great. We definitely think it's an interesting way to look at things, and I like that you guys. I know Health HIV has done some stuff. So just anecdotally, we've done the self-assessment, which is not always the most accurate. So I like that you're having the peer educators or secret shoppers and others kind of us do the assessment of those 4 domains. So that's great.
And how far along are you in the creation of this tool?
I would probably say we're probably within the next month, because we have 2, because our program mechanism group and our cultural competency group is working on this. So they're actually it'll be an entire agency assessment. So they're sort of integrating the 2. So we're looking at not just cultural competency, but we're also looking at fiscal responsibility and all that. So they're working on that too. I would probably say in the next month, because the reason we need to get that up and running is because of our peer educators will be on board. So I would probably say within the next month we'll probably have a final tool.
Great.
That's great. And Ken, I don't know if you heard, New York was just sharing with us that they've done some listening sessions, and will be doing some more in the future to kind of talk about this as well as another kind of tactic or strategy for kind of getting more information about cultural flexibility and determining how to do some programming around that. So that's kind of what they've been working on as well. I know we're getting down to our last 2 minutes, and I don't want to close off without if folks have other comments, but I did want to just take a really quick minute to post something to the group that Dawn and I were talking about, and I mentioned it briefly before, and I think it was before Ben joined. But what we were talking about, just to make sure that we're not completely exclusive or exclusionary of the other 1509 grantees who most certainly would benefit from some of this material and information as well as they're implementing their program, was that if there's something that's particularly different, or Dawn's not hearing it on the program calls and things that we think would benefit other folks as they're implementing their work plans, that we might find a way to do a short little write-up, interview the folks at the health department leading it, or just ask them for a paragraph if there's time to write up different kind of things, such as the tool you're developing in DC, or some of the work that New York is doing with the Department of Education, anything that's kind of an interesting model that other folks might be able to implement. And the reason I'm mentioning this to you all, and Ken doesn't know this necessarily since he wasn't on the first call, is that we had discussed kind of keeping all of the information that we're sharing in this EOP sharing it internally, and not necessarily opening it up to a wider audience without approval from everyone or the individual that was speaking. So if that's something that you're comfortable with, we might explore a way to write some of these things up so that we can share them. So I just wanted to see if that was something that you guys were okay with and or interested in doing, and would be okay with that, so that we can think about a process for implementing that kind of an activity.
Sure.
Okay, great.
That's fine.
Okay, great. Yeah, I do think we definitely don't. We want to make sure other folks have access to the same information if we think it's appropriate to share. And it's so great hearing what everybody's doing. And I just really think without having these conversations and without having 1509 wide calls, you don't really have that opportunity. So what we're going to do kind of moving forward then is, if there's something that we want to just reach out to you guys, we'll do it individually after the calls, and we'll figure out a process for it. So stay tuned, and we'll just make sure we obviously double check with anyone before we share any information outside of our community of practice. I did also want to mention, and this is on the slide for next steps, that we are trying to get the Johns Hopkins folks for our May call, and they seem open to it. I think it's just going to be a matter of when we find a date that everyone can be available. That one, because of the topic area and because it's so important during these initial implementation stages, we did want to open that to the other 1509 jurisdictions, so the other 4 health departments can participate. So whether that's May or if it has to go in June, depending on scheduling, we are going to allow the other folks to listen in as well. So hopefully that makes sense and is okay with everybody. So if we're doing the evaluation piece with Johns Hopkins, again, it'll be open to the larger 1509 grantees. Does anyone, I don't want to cut off, but I know we all have other things and we're 2 minutes over. So I just wanted to let you guys, if you had questions, other comments, specific things that you definitely want to make sure we talk about next time that you didn't get to really delve into enough, just allow you some time to comment on that before we sign off. All right. I hear the crickets in the background, so I think that means everybody has
Nothing on our end. We were
to go to their next meeting. I'm sorry, Lena, did you say something? Sorry.
Yeah, we don't have anything on our end.
Okay, great. Yeah, I know everybody has APRs due, as do I. So we'll sign off from here. We're going to make the recording available if anyone else from your team wants to listen to anything, and we'll reach out to you guys very shortly to schedule our next date and talk about some next topics. So thank you all. Have a great rest of your day and a great week, and we'll be in touch soon.
Great.
Thank you.
Thank you.
Bye. Thank you so much.